for coming, ladies and gentlemen. We will begin shortly, so please make sure that you are on mute, but we encourage you to turn on your video camera. We will begin the webinar. Thank you.
Okay, sorry everyone, we're having some technical problem with the operator, so I'll try to play the video from our YouTube while we're waiting for Professor Benny Tjahjono to join us. Okay.
Pemerintah telah menetapkan COVID-19 sebagai jenis penyakit dan faktor risiko yang menimbulkan kedaruratan kesehatan masyarakat.
Positif COVID-19 di Indonesia sudah tembus 1 juta pasien. Positivity rate Indonesia pada Minggu 24 Januari 2021 akan mencapai 3,24%.
Saya Valen, saya salah satu pasien positif COVID-19 beberapa waktu yang lalu.
Saya Kebijakan dari Fakultas Kesehatan Masyarakat Universitas Airlangga.
Mahasiswa S.kep Kesehatan Masyarakat Universitas Airlangga.
Hai, saya Iman, saya seorang dosen. Saya juga seorang penyintas COVID.
Saya Nita, penyintas COVID-19.
Saya Iksan, dan saya penyintas COVID-19.
Saya penyintas COVID.
Nama saya Ilham, saya adalah pelajar SMA.
Nama saya Belum Siswantara, saya merupakan penyintas COVID.
Saya tertular oleh kedua orang tua saya
Dari kluster keluarga,
Yaitu dari salah satu anggota keluarga saya yang terkena COVID-19 dari rekan kerjanya. Sebelumnya saya masuk kantor untuk melakukan praktikum bersama mahasiswa, kemudian juga mengisi salah satu webinar secara offline.
Ketika sebuah acara dan ada salah satu undangan yang hadir, jadi dia masih positif, kemudian saya kena tracing dan akhirnya saya dinyatakan positif.
tidak bisa dilacak, ada banyak kemungkinan terpapar dengan COVID-19.
Di awal gejala yang saya rasakan itu yang paling terlihat itu adalah anosmia, sehingga memang cek atau swab.
Saya sempat mengalami demam pada hari pertama dan rasanya sangat tidak enak karena seluruh badan itu pegal dan terasa agak sakit dan lemas dan bergerak.
Saya itu tidak mengalami gejala apapun sampai sembuh. Saya juga tidak mengalami gejala apapun.
Bahkan tidak enak, pegal-pegal dan sakit semua terasa di badan, ada ruam-ruam yang muncul. Dan COVID-19 ini benar ada, selalu patuhi protokol kesehatan, memakai masker, menjaga jarak dan cuci tangan.
selalu menjaga kesehatan, menjaga pola makan, mematuhi protokol kesehatan, dan melakukan olahraga secara rutin untuk menjaga stamina kita dan juga meningkatkan imun tubuh kita. Karena di sini bukan cuma memikirkan tentang diri kita sendiri, tapi kita juga memikirkan tentang kesehatan orang lain seperti kesehatan orang tua kita ataupun kakek kita yang memiliki usia lebih lanjut.
Tetap jaga kesehatan, tetap jaga kondisi tubuh, istirahat yang cukup, tetap berolahraga, dan selalu taati protokol kesehatan.
Kawan-kawan sebaiknya tidak kumpul-kumpul dulu, tidak mengadakan pertemuan yang rapat.
Kita jangan sampai lengah untuk memperhatikan protokol kesehatan. Kita harus selalu memakai masker ketika kita ada di luar rumah. Kita juga harus cuci tangan pakai sabun. Kita juga harus menjaga diri dari kerumunan ketika kita nanti ada di luar rumah. Benar-benar kita harus jaga diri kita. Kita harus jaga imunitas tubuh kita dengan minum multivitamin secukupnya.
COVID-19 ini dampak negatif bagi tubuh kita ini sangat tidak mengenakan dan sangat buruk. Sehingga teman-teman semua dihimbau untuk selalu jaga jarak, tidak berkerumun, dan tetap di rumah saja. Dan jangan lupa untuk selalu menjaga kesehatan dan menjaga kebersihan.
Kita harus tetap berhati-hati dan terus menjalankan protokol kesehatan. Jangan sampai kita lengah ketika kita sebuah acara, kita membuka masker kita. Masker itu yang paling utama ketika acara, karena itu perlindungan kita yang terakhir ketika kita bertemu dengan orang lain, sering-sering cuci tangan atau hand sanitizer, jangan terlalu berdekatan dan berkerumun. Jangan lupa pakai maskernya terus. Pakai maskernya juga yang benar.
Teman-teman, kalau bisa jangan sampai nurunin masker ya. Dan kalau sudah sampai pulang ke rumah, semua baju langsung dicuci, apalagi kalau barusan kontak dengan orang yang positif.
COVID ini ada, selalu waspada dan 3M, selalu patuhi peraturan.
Jangan banyak begadang, kemudian makan makanan yang bergizi seimbang secara tepat waktu, dan yang ketiga juga harus selalu beraktivitas fisik secara rutin supaya imunitas kita tetap terjaga dan tidak sampai terkena COVID-19. Selain itu juga 3M juga sangat perlu ya, menggunakan masker, kemudian sering mencuci tangan dan menghindari kerumunan. Semoga kita semua selalu terhindar dari COVID-19 dan semoga pandemi ini juga segera selesai. Salam sehat.
Alright, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Waalaikumsalam.
Greetings to our speakers, to Professor Beni Tjahjono, good afternoon, sir, and also to our second speaker, Ms. Rista Fauziningtyas, good afternoon, ma'am. And also good afternoon to all ladies and gentlemen in this meeting room. Welcome to the World Patient Days. Welcome to the World Patient Safety Day Research Week, Day 4, with the theme Organizational Culture and Patient Safety. I am Nindya Rifani, and I will be the MC and the moderator for today's event, starting from 1:14 in the afternoon until approximately ends around 3 in the afternoon. Since it seems like our first speaker, to Ms. Rista Fauziningtyas, is already in the room, let's begin today's webinar. But before we begin, I would like to introduce our speakers. So to the operators, please show us our first speaker, Ms. Rista Fauziningtyas, curriculum vitae. Our first speaker, Ms. Rista Fauziningtyas, Sarjana Keperawatan, Nurse Magister Keperawatan, will be talking about understanding of resident safety culture in nursing home located in Indonesia. So our speaker is a lecturer at the Faculty of Nursing, Universitas Airlangga, and is a secretary of Indonesian Gerontic Nurse Association for East Java region. Let's see. Our speaker is also a PhD candidate at University of Malaya in Nursing Science program. Our speaker has done many research and publications, with her latest publication from 2021 titled Informer Carer's Knowledge of Traumatic Brain Injury Questionnaire, Initial Development and Validation. So our first speaker, Ms. Rista Fauziningtyas, will bring the topic of understanding of resident safety culture in nursing home located in Indonesia. So now moving forward to our next speaker, Professor Beni Tjahjono, I would like to introduce our second speaker to the operators. Please show us our second speaker, Professor Tjahjono's curriculum vitae. Our second speaker, Professor Tjahjono, will bring the topic. Professor Tjahjono will bring the topic, do reliable organizations lead to patient safety? To the operators, please show us our second speaker, Professor Tjahjono's curriculum vitae. So Professor Tjahjono is a professor of sustainable supply chain management at Conventry University, United Kingdom. And also, Professor Tjahjono is leader of the Sustainable Production and Consumption Research Cluster at the Center for Business in Society, or CBIS. Professor Tjahjono has published over 100 papers in varied academic journals, conference proceedings, books, and also practitioners' journals and newspaper. Our speaker has a high success rate in co-authoring peer-reviewed journal papers with Indonesian scholars at mostly Q1 level. Professor Tjahjono his research track record has been demonstrated by winning a number of research grants from, for example, from the Engineering and M.Kep, a Physical Research Council, and then from Economic and Social Research Council, and also from Academy of Medical Science, from Innovate UK, from European Union, and also overseas funding agencies, and directly from the UK industry sectors. And one of Professor Tjahjono's PhD project is titled Towards Healthcare 4.0, Cyber Physical System in Healthcare. So that's a brief introduction of today's speakers. So without further ado, I would like to welcome our first speaker, to Ms. Rista Fauziningtyas. Ms. yours.
Thank you, Ms. Nindya, as moderator today. And also, thank you for Ibu Inge as a Chief of the Patient Safety Research in University Airlangga, and also Prof. Benny. Thank you for the time. Okay, I will share my screen. Is it already seen on the Zoom? Okay, my voice is already clear also. Okay, thank you. Okay, before I start the presentation today, I will read the outline. The first is overview older population in Indonesia, and then second, research on safety culture in nursing home, and the last is what we can do. What overview? Demographic condition of older population. Indonesia is experiencing population aging now, and then the Indonesian life expectancy increased in 2019. It's about 71.39 years, and then the proportion of the older adult population is also increased, now more than 10% from the total population. In 2019, the number of older adults was projected to increase from 27.5 million to 57.0 million. So it is about almost 18% from the total population. Conversely, the population of children declined from 44% to 26% in 2020. In 2017, 5 provinces had reached the old population structure, so the old population is more than 10%. Yogyakarta, Central Java, and East Java is the third number, and then Bali and West Sulawesi. What's the impact of the demographic condition? The first is, of course, reducing the rate of labor force participation, and then it also make the financial difficulties increase with the loss of income earning power, and only a small proportion of older adults are covered by pension based on their employment record, and social pension is also inadequate, and 50% of the older population is actively involved in the workforce. So the aging population bring financial tension for Indonesian economic. Yeah. And the second, of course, it will increasing the proportion of older adults who live alone and family with older adults. In 2019, it is about 27.88% of the older adult in the household, and about 10% of them live alone, and 2 million neglected older, and 1.8 million older adult have the potential to be neglected. Both of this condition is maybe must become our attention. And then the third impact is increasing the health problems. 1 in 4 older adults has been sick in the past month, but the health insurance has not reached all of the older adults. Only 69% the health insurance they have insurance, and the health insurance most widely owned by the older adult is BPJS, or national insurance coverage. Okay, this is an overview for the health and welfare service for older adult in Indonesia. Actually, the government has provided primary healthcare for them through the Puskesmas Ramah Lansia, or the older adult friendly community health center, and the Posyandu Lansia, or community level health station for older adult. And then the next level healthcare is of course in the hospital. They provide inpatient and outpatient services. And then the welfare improvement program is given to neglected, poor, and sick older people from the social department through the government-owned nursing home. Now focus on the research on safety culture in nursing home. Introduction. Okay, the older population is very vulnerable to the adverse event because they often need complex treatment caused by multimorbidity, polypharmacy, and multiple functional limitation. Some of them live at long-term care, such as nursing home, or they live with their family. The older adult in East Java who live in nursing home, government-owned, actually not a lot of people, but only 616 people in 2004, and increasing until 872. It is only 0.04% from the total population in East Java. And it's estimated that the number of older adults living in a private nursing home is about 2,300 people, or about almost 1%. And the total is only 0.13%, only not reach 1% from total population, only a little. But the little thing is also need our attention. Operator, Caring in the nursing home is little bit different with the hospital. The caring process in the nursing home is often characterized by high workloads because there is a lot of resident or a lot of older people in there, but they only have a minimum staff or nursing staff, and they have high staff change or turnover, and then difficulties in recruiting competent new staff, and suboptimal quality of care. And this condition have a serious impact on the health and safety of older adult in nursing home. And also some research declare that nursing home are still lagging behind in developing and implementing resident safety than the hospital. In East Java, there has been no collective reporting of resident safety incident to the Social and Welfare Department. As we know that records related to falls, injuries, pressure ulcer are usually carried out depending on the policy of its nursing home. So it's only locally in the each nursing home, and also limited study about safety in nursing home in Indonesia. So a lot of study about safety, but most of them is in hospital. The research question. The first is, what are the factors determining safety culture in nursing home located in East Java, Indonesia? And the second is safety culture related to quality of care standard. It is contractual, false, nutritional status. This is with the body mass index below 18.5 kilogram per meter square, and then the pressure ulcer, hospitalization, infection. This is content 2, lung infection, and urinary tract infection. And the last is activity daily living decline in nursing home located in East Java, Indonesia. The aim of this study is to examine the relationship between safety culture and quality of care standard in nursing home, to examine the factor determining resident safety culture in nursing home located in Indonesia. Other study on nursing home safety culture, all study I took from the other country. There is I can find it studies in Indonesia. For the recent study about safety culture, there is several factors that have been studied. This is 6 articles, have an inconsistent relationship with safety culture and error communication. These factors such as staff turnover, staff education, job position, the age of staff, and the length of work. And for the association between safety culture and quality of care in nursing home, from the 28 studies examine the relationship between safety culture and indicator of quality of care in nursing home. And some of their findings also were inconsistent. Some researchers have found an inverse relationship between safety culture, deficiency in health, the number of substantiated complaint and medication error, pressure sore or pressure ulcer, urinary tract infection, and falls. There is some delay, technical error. Operator, I don't know why. Okay. Method, design of and activity of this study. The first is the design is a cross-sectional study. The activities is measuring the demographic data, measuring safety culture in nursing home, and also measuring resident quality of care in nursing home. The tool for the first activity, we use demographic survey, and for the second is I use Indonesian nursing home safety culture. Nursing home safety culture on nursing home safety culture questionnaire, the Indonesian version, and then for resident quality of care, the tool is the secondary report of hospitalization, pressure ulcer, contracture, falls, nutritional status, and decline of ADL. Okay, for the population and sampling, the population is all staff, including top managers, nurse, social worker, physician, administrative, and supporting staff. Supporting staff include the driver, the kitchen staff, and also the security staff, and then who work at the nursing home in East Java. For the research setting, this research involves 11 nursing home in East Java, 8 is public nursing home or belongs by the government, and then 3 private nursing home. The data collection April to July 2021. The sampling use multi-stage cluster sampling with the inclusion criteria, have a minimum junior high school education, work as staff with minimum work experience a month, full-time worker in the nursing home. The data analysis, for the first objective, we run descriptive tests and also path analysis use AMOS. And for the second objective, also run the descriptive test with a mean, median, frequency, and proportion. and also path analysis use AMOS. For the instrument, the demographic data, we measure age, gender, marital status, education, salary, work position, duration of work, work experience, training about safety, employment status, and type of nursing home. And for the nursing home, we use nursing home survey on patient safety culture by Westat organization. This is actually 43 items with 12 domain with a 5-point Likert response, but we already tested for variability and reliability. There is a reduction for the item, become 32 items. And for quality of indicator report, we use 7 indicator of quality of care. Okay. This is the different, the HOPSG original versus Indonesian version. So there is some reduction from the dimension. Staffing, the original version is 4, become 2 items, and compliance with procedure from 3 items become 2 items, and in the non-punitive response to mistakes, 4 items become 2 items, hands off 5 items become 4 items, and the total of the Indonesian persons is 32 items. Okay. For the characteristic respondent, the age, the minimum and maximum age is 18 until 67 years, and for the gender, mostly is female for the respondent, and the education mostly senior high school. They already, and the second is the diploma 1 or diploma 3. And for job category, mostly is a social worker and physiotherapist, and no physician in the nursing home, because the physician is only sometime from the puskesmas, and they go to the nursing home only give some treatment for a few times. So there is no full-time physician in the nursing home. Okay, for the indicator of quality of care, hospitalization, the highest percentage of hospitalization is nursing home number 4 with a 16.67%, and for the pressure ulcer, the highest is in the nursing home number 2 in the 4.55%, and for the contractor, the highest incident is in the nursing home number 2 and nursing home number 11 with a 9%. And for activity daily living decline, the highest number is in the nursing home number 3, is about 69%, almost more than 15. And then for the falls, the highest incident is in the nursing home number 8, it's 10%. And for malnutrition, for nursing home, they don't have documentation about the malnutrition. The highest malnutrition happen in the nursing home number 1, and for lung infection, including COVID and bronchitis at COVID, and also tuberculosis in the nursing home number 1 with the presentation 5.06, and for urinary tract infection, both because of catheter or without catheter. In the nursing home number 8, it is about 10%. Okay. How about the factor related to resident safety culture? From the testing, the factor that related to the safety culture is age, staff age, and works experience, and give direct service to resident with the age with the pay value 0.048. So the conclusion is significantly negative relation with safety culture. So the younger age, the higher they get the safety culture score. And for the work experience, they have a significantly positive relation with safety culture. So the longest work experience, they have great higher safety culture score. And direct service to resident it have significantly negative relation with the safety culture. So staff who don't give direct service to the resident or to older adult, they have higher safety culture score than who give the direct service to the older adult. Okay, for the safety culture related to quality of care indicator, the hospitalization and pressure ulcer, it has relationship with the safety culture. So safety culture significantly positive relation with the hospitalization, and safety culture significantly negative relation with pressure ulcer. In this hospitalization, the higher safety culture score, it's mean also higher hospitalization. And for the pressure ulcer, the higher safety culture score, it decreased the number of pressure ulcer. Okay, for the other, there is no significantly relationship for activity daily living decline, contracture, falls, lung infection, and urinary tract infection. Okay. Factor related to safety culture, X related to safety culture in line with other study by Bondevik, and the younger employees more easily identify the possible risk, recently trained, and have been introduced to patient safety issues to a broader extent than older staff. And then the direct care service related to safety culture, this finding also supported previous study by Castle, Kaplan, and Castle et al. In also a study in a nursing home. This study saw a higher range of safety culture score for staff administration than direct care workers such as healthcare workers. Okay. For the works experience related to safety culture, staff who worked longer had a positive perception of safety culture. This result differed with study by Bondevik. Work experience revealed the staff attachment to their work and the workplace. The longer a person works, the more experience they get. So in the other result, it is a different result from this study. And then safety culture related to quality of life care indicator, high score of safety culture had lower rates of pressure ulcer, supported by previous study by Browner et al. In USA, and safety culture related to hospitalization support by previous study with the Pillsbury, Hewitt, Steer, and Bowman in 2011. Okay, what we can do for the next, safety culture in nursing home is needed to develop because it's very lagging in the implementing and development. And the government should strengthen policies to improve the security and service quality of nursing home. But the research about safety culture in nursing home related to other quality of life, other quality of care indicator needs to be done, such as the satisfaction of the user for resident and family or adult family. Increased frequency of training and orientation on safety culture topics for all nursing home staff must be implemented because all of them have a role in creating a positive safety culture. Thank you. I come back to moderator, India.
Thank you so much, Ms. Rista Fauziningtyas, for the amazing presentation. Yeah, it seems like Professor Tjahjono is still preparing for his presentation. So in the meantime, let's move to our next agenda, which is a Q&A session with Ms. Rista Fauziningtyas. So to the audience members, if you have any questions for Ms. Rista Fauziningtyas, you can submit the questions through chat or by raising your hand. So we'll be waiting for the questions. Yeah. You can drop the question in the chat or by raising your hand, then can ask it directly to Ms. Fauziningtyas. The recorded version of this presentation, the recorded version of this webinar will be posted on our YouTube channel. So after this webinar ends, the recorded version will be posted, will be uploaded on our YouTube channel at Pusat Riset Keselamatan Pasien. Yeah. To the audience member, if you have any questions to Ms. Fauziningtyas, please submit it through the chat or by raising your hand. We'll be waiting for the question. Yeah, it seems like there's one question from Ms. Ika Nurpratiwi. Yeah, to Dr. Rista, in your experience, why does each nursing home have different incidents related to the residents' culture? Ms. Fauziningtyas, one question.
Okay, thank you. Because there is no standard for documentation for older adult or resident who live in nursing home. There is sometimes they have documentation about falls, sometimes about health conditions. Still no standard for it. So maybe the government must have more policies or give some attention for the management of the nursing home. For now, the nursing home belong by private. There is private sector. There is like for evaluation from the social department. So maybe now we have to start because the population of older adults who live in the nursing home is increased in every years. Thank you.
Thank you so much. To Ms. Ika Nurpratiwi. The answer is good enough. So let's move forward to our next agenda. I would like to welcome our second speaker, to Professor Tjahjono. Professor Tjahjono, yeah. Good afternoon, sir.
Good afternoon and good morning from the UK. I'm sorry I missed up the timing.
It's perfectly fine, sir. So the screen is yours, sir.
Okay, just 1 second then to share my screen. All right. Which one is this? This one. Okay. Can you see my screen? Yeah. Patient safety. Okay. Right. Okay. Again, good morning. Again from the UK, and thank you very much for inviting me to this event. To my dear colleague, Bu Inge. How are you, Bu?
Pagi, Prof.
Selamat pagi. Okay, so I've listened to Bu Rista's presentation earlier on, very interesting, and the methods, and also, of course, talking about the safety culture. And let me just quickly introduce myself. I'm a professor of sustainability and supply chain management. I am probably not in the area of medical or patient safety per se. However, I have something to share with you that your community might be beneficial from my approach. So my research is into the organizational issues of safety, and I would like to present to you a theory that we've been using over the last 2 or 3 years to view. So you're probably familiar that in the area of business management, every time we do research, then we need to adopt a theoretical lens. And this theoretical lens is called reliability organization. So my presentation today, I call it patient safety, and the research questions that I'm trying to, sort of the umbrella research questions I'm trying to impose to you is, do reliable organizations lead to patient safety? Of course, this is a very high-level question. We'll see the extent to which my presentation will be able to answer this question. So I'm from Conventry University. I work at the Center for Business and Society, and you're welcome to visit us one day if when it's possible. Yeah. Okay, so three key takeaways that I'd like to convey to you today is the first, obviously, the lens, the theoretical lens to investigate the link between reliable organizations and patient safety. And in order for me to be able to deliver this lens, we'll be using a very small studies, just initial studies about nurses in an A&E department, and obviously afterwards lessons learned and future work. And maybe this is where the area that we can explore in the future on how we develop the models. So my presentation is going to be purely exploratory, and the previous presentation by Rista is explanatory or quantitative. So maybe in the future that we could do is to combine the development of the models that I'm going to show to you, and then testing of the model through survey and questionnaire. So the background, obviously everybody here in this forum will agree that health services are in great need for what? For reliable personnel and equitable distribution of workers. So this is a very critical requirements for today's healthcare organization, and also patient safety is paramount, is very important, especially in accident and emergency department. And often in practical life, like in the UK and many other developed countries, nurses are actually at the front line of the service, the healthcare services. And they have to be competent and they have to be experienced in their fields. But more importantly is that how the organizations create a structure, create an environment, create a culture whereby safety can be promoted. Yeah, and that's the reason why there is a need for an organization to be more safe, to be safer, to be more reliable in the future. And there is a need for academics like us to look into the theoretical lens on how to investigate these phenomena. So research question: to what extent high reliability organization theory or principles apply within the accident and emergency operations? And this is the study that I will explain to you in a few moments. So what is high reliability organization, or HRO? So it is a theory. It is an organizational theory that is found or sort of originated from both management and science area. This theory particularly useful to explain or to elaborate situation or circumstances where everything is in operation in hazardous environment, yeah, and the consequences of failure, yeah, for meeting this requirements is catastrophic, yeah, and the kind of operations that we talk about is usually complex, yeah, very demanding, tightly coupled. Tightly coupled means it has to follow certain procedures, has to follow certain processes, and very risky. Okay, and the targets is obviously to avoid any accidents, to avoid any catastrophic accidents by minimizing the errors, minimizing the near misses, and sustaining the performance across the range of operational conditions. So what kind of operation are we talking about? For example, in nuclear submarines, yeah, everything has to be controlled, everything has to be tightly coupled, yeah, everything has to follow a certain command and chain. Yeah, otherwise, obviously it's very, very dangerous environment. Secondly, power plant. Again, if it's nuclear power plant, the system is huge, it's big and complex. And another example is air traffic controllers, as you imagine, in air traffic controllers, safety of the passengers, safety of everyone is also paramount. So this is where the applications of HRO are very, very popular, especially in the beginning of 2000. But now HRO has been used in other areas outside engineering and sciences, and especially in the case of healthcare, it's been used in some context of healthcare management, especially also in the accidents and emergency. So one of the important principles in high reliability organization theory is the so-called collective mindfulness. And as you can see in your screen, mindfulness. So it means that everybody has to be mindful. Yeah, mindfulness is an awareness and the capacity owned by the stakeholders of an organization for any actions. Yeah, so everybody, when they do some action, has to be mindful. And the mindfulness will jointly facilitate everyone to be capable of discovering and managing unexpected. I'm sorry, I still woke up in the morning, cannot say the word properly. Unexpected events before they escalate into crises and catastrophes. Okay, so this is a very important principles within the high reliability organization. So everyone must have mindfulness, and this mindfulness has to be collective, because obviously we are working in organization, and therefore we need to have that mindfulness as a collective mindfulness. I hope that makes sense. So moving on now to the principles of high reliability organizations. The first one is called preoccupation with failure. So we need to be preoccupied with failures. I know it's very strange, but I'll explain to you in a minute. The second one is probably a bit more easy to understand. Reluctance to simplify. So anyone who are upholding reliability systems has to be reluctant to simplify things. Yeah. So and everyone has to be sensitive to operations, and they must have commitment to resilience. So they have to be resilient, and finally they have to defer anything to expertise rather than rank. Let's take a look at this one at a time. So the first one is the preoccupation with failure. So we need to be preoccupied. Yeah. So it means that we need to be persistent, with a persistent caution of the potential unexpected events. Yeah. So we need to be wary. We need to be sensitive to any potential unexpected event. So if you see simple examples of this would be if someone drops water in the corridor of a hospital, then someone has to be alert. Hey, this is dangerous. So and immediately alert, immediately pass that information to anyone to put a sign, let's say, of this hazard. So even a small signal, has to be a signal of failure. So everyone has to treat this signal or small failures as a sign or alarm for a larger, danger. So they need to learn from small mistakes. So if anyone made mistakes, probably okay, but everybody has to learn from these mistakes and then try to strive not to repeat the mistakes. And then they need to report small failures that occur so that they're not neglected or repeated. So here we go. So the first principles of a high reliability organization would then say, everybody has to be alert, everybody has to be vigilant. So that's the first principle. Second, everybody must have a sense of following procedures, following standards, and they must be reluctant to simplify or to cut corners. Okay, so they must uphold various checks and balances. They must encourage people to follow standardized procedures. Okay, and in some operations, in some engineering applications, there are backup or redundant processes. So if the first process failed, they need to have backup processes. People must not accept if something is simplified. So they must report if they can see or if they see circumstances where people actually simplify operations for the sake of, I don't know, simplifying time, for the sake of ease of or convenience. These kind of things must be avoided. So that's the second principle. We must be reluctant to simplify procedures. Third, we must be sensitive to operations. So we need to look out for or seek to understand the big picture of operations through transparencies and real-time interactions. So it means that people are all expected, the management will expect people to be sensitive to near misses, small failures, and then share this amongst others. So in the first principles, I said to you that we need to be vigilant, we need to be aware, we need to be alert, but that's not enough if you do not share it. So the third principle is that we need to share this best practices, share this information to others to ensure that safety, to ensure safety by being highly sensitive to the way someone works in the system, to keep them from ignorance or indifference to the standard procedures. So again, the third principles relate to the first and second. The fourth one, we need to be resilient. We need to embrace preparedness by building capabilities and resilience. So simple examples to this principle: someone makes mistakes, someone has very stressful life or stressful shift, put it that way, and the management has to recognize that and build some sense of being resilient. So do not make mistakes again. It's okay. You make mistakes, but you learn from the mistakes. Be tough and be resilient for the future to uphold this standard and safety. Here we go. So the last one I wrote there. It encourages everyone to learn from failures and help an organization to always be committed to prevent failures from recurring. Okay, so resilient is a key here. And I guess if you look at what we have at the moment, we are undergoing a very tough time at this COVID pandemic, and indeed resilience is really, really important and really critical to our lives. And you will see that everywhere, people going through an up and down situation. Even in the UK now, if you heard the news, we have opened to as the way, as we were before pandemic, but now obviously the case, when the country is open to that, and it's more vulnerable to cases being increased, and you see cases being increased, and we will, if the rate is going that way, throughout the month, then the government may decide to close again. So that's the consequence of that. the last is very interesting because this is to do also with culture. And often we defer or we refer something to someone who are more senior, someone who has a higher rank, someone who has more authority than us, rather than expertise. So the last principles of high reliability organization, it says that a reliable organization must encourage people to defer to expertise. Yeah. So when attempting to solve a problem, especially during emergency crisis, decision-making has to shift to the person or people who have the most relevant expertise. Yeah. So when something out of ordinary, something special, something extraordinary, something unprecedented situation happens, HROs has to share the information to individuals regardless of their hierarchies or ranks. Yeah. And this is, again, as I said to you before, there are cultures, there are practices whereby we always want or we always ask for advice, ask for delegation from someone who has authority or someone who has higher hierarchical rank than us rather than expertise. So that's the 5 principles of high reliability organization, and hopefully from these, then we can now move on to the second part of my presentation, which is a bit of story on how I try out this theory, HRO theory, in the context of healthcare. So what do we do? Let me just check. Yeah, okay, so what basically we are doing, or we did qualitative study through interviews, and the sample, the selection of sample, as I said before, a number of nurses with different background, different expertise, different experience working in an A&E department in hospital. And the data was analyzed using in vivo, qualitative techniques, thematic analysis. We code the interviews as transcript, and then we group them into themes and we discuss. So that's the methodology of my research. So some of the guiding questions, certainly because we are using HRO as the theoretical lens, then it is natural that the questions would be derived from this theory. So for example, principle number 1, which is the preoccupation to failure, we look for something, we look for sudden inspections from the management to the emergency room, yeah, with the hope that we can capture or we can catch signs of failure that might occur that could jeopardize the patient's safety. Okay, so we ask this question to the nurse: do they experience sudden inspections from the management? Okay, and then the next question, for example, we wanted to know how many, how frequent are the near misses in the emergency room as a result of perhaps carelessness, forgetfulness of colleagues. Yeah, we don't need to name the colleagues. We just want them to tell us whether they are aware that their colleagues make mistakes, whether their colleagues forget something, and so on. So that's just the kind of guiding questions. But again, because we are doing interview, we have a more flexibility to ask this question and the follow-on questions afterwards. And second one is the principles number 2. I don't want to go into detail of that, and you can have this presentation later. So these are some examples of the questions. Now moving on to the profiles of the samples. So like I said before, we have a broad range of experience of the nurse, but the minimum of 1 year of experience working in A&E. And they also have various contracts. Yeah, from, of course, at least there are 2 types of contracts, permanent and also non-permanent nurses. They work in three shift patterns, sort of morning, early morning, and then day and late night. Before we interview them, there are some sort of qualifying questions, because we wanted to really understand, we wanted to really interview those nurses who have basic knowledge about patient safety. Yeah, and that's the reason why we need to confirm, we need to just ask some questions about that. And unanimously, they confirmed that they have heard about patient safety, although not all of them were able to explain or articulate the definition of patient safety according to the literature that we know. And often they actually use real life to confirm. So for example, if I ask questions, are you familiar with patient safety? What do you mean by patient safety? Is it this example considered as patient safety? Yeah, or not? So that's the profile of the nurse. So a bit more detail on that. So we only interviewed 8, 12, 14 people, because it's a qualitative research, so we can deal with small samples of participants. And then the shift patterns, mostly working in the afternoon, some of them in the morning, and only one work at night shift. And the majority of the nurses that we interviewed are non-permanent contract. That would be interesting to hear the views of this, because obviously some non-permanent nurses would like to be permanent one day. And we are fully aware of that as a potential bias of the questions of that. And also the being permanent, also they may not be there is also a potential bias from the permanent nurses for the reasons that they are defending the management. Yeah, that's the kind of things that we are aware of that. So what do we find? So the first one, with regard to preoccupation with failures, you can see that the majority of the nurses reported that the hospital management routinely carries out sudden inspection. But what's interesting is this inspection to prevent error and not always embedded in their day-to-day operations. I think I remember one of or a couple of them mentioned that the inspection was needed because the management themselves are required to do sudden inspections. Yeah, so it's more like external pressure for them to do sudden inspection rather than the the embedded as the day-to-day operations. Nurses also have reported that they experience near misses. Yeah, for example, due to traumatic patients, raging babies, and other minor incidents that involve colleagues in the same department. Interestingly, they also reported that there's some slow responses to complaints about procurement of basic PPE. So I have to say though that this research was conducted prior to pandemic. Yeah, so I forgot to mention that the circumstance in this research are in the normal situation, not in the highly emergency situation. Findings number 2, which is reluctance to simplify. So as I said to you before, we need to follow procedures. We need to we must not simplify our operations. So what do we find? So we find that debating arguments amongst the respondents. So it means that there are contradictory opinions. Yeah. There are some people actually said, we are using old SOPs, which is not very efficient. Yeah. We achieve the same result by skipping or by changing the sequence. So I'm not familiar with exactly what they're talking about, but it says that it seems that there are 2 conflicting opinions there that on one hand, they're saying that we have to follow SOP as it is. We don't need to think, because SOP would develop to ensure safety. On the other hand, they say, yeah, we know, we have experience, we are experienced enough to ensure the safety, and therefore it's okay. we pass that certain SOPs. So it's clearly that in that particular instance, the reluctance to simply a principle is not applied, and enforcing the procedures or standard operating procedures is not part of their safety culture, administrative culture, but it is part of administrative rather than an effort to control or to ensure the safety. I mentioned earlier and before that some respondents or some nurses are actually reluctant to use the new SOP due to its complication and inefficiency. Oh yeah, I forgot to mention that the last part there, I asked the questions, in your experience, did you come across a situation whereby the old SOPs were changed to the new ones? And they say, yes, we have the new SOPs, but you know what? The new SOP is even worse. It's taking even longer than the old one. They think that, but unfortunately, they didn't realize why the new SOP changed to the old SOPs. Sorry, the old SOP changed to the new SOPs. For what reasons? For what safety reasons? Finding number 3, sensitivity to operations. So it's clear that in this particular instance that nurses are actually communicating some of the results to other colleagues, to their peers. As I mentioned to you before, if this principle means that if you learn something new, if you come across something that hasn't happened before, extraordinary, unprecedented, then please share it amongst your colleagues. And they have done some of this. However, the way they do that, the way they share this information to the colleagues is not part of the organizational culture, but rather it's part of the social, what's the word? Social network. Yeah. So they're using WhatsApp, for example, WhatsApp groups. They're using, I don't know what it is that they're using there. But rather than the hospital itself creating a mechanism whereby they can share, they are using but I'm sure, I'm not saying that the hospital itself do not have the mechanism. I'm sure they have the mechanisms, but according to the nurses, especially the new ones, they're saying that they get the information from the senior nurses through, like I said, WhatsApp. Commitment to resilience, again, people are being encouraged to be resilient, people are nurtured, people are being looked after to do that. And let me just take a look at this. I haven't seen any extraordinary findings in this principles. Failure to save life and distressing emergency. Oh yeah, so the last one is interesting because this is happening particularly for the new or the less experienced nurses that this distraught they are encountering when dealing with the patients may affect their spirit. They may affect their psychological attitude and behaviors, and therefore some of them are actually considering moving to a different department because of the stress and pressure. Yeah, so it wasn't apparent from this organization that the management actually upholding this principle, how to ensure that everybody are becoming more resilient. And finally, this is interesting to note that people with a higher position in the hospital, higher hierarchical ranks, I would imagine, should be more respected than, according to the nurse, they said, people with higher ranks and hierarchical position should be respected more than with expertise, which is very interesting. Some nurses suggest, however, that doctors should be respected more than for their medical knowledge and capabilities to handle patients. this is interesting, ladies and gentlemen. Probably you said that, yeah, but Benny, but in reality, we always defer to those who have expertise, especially in hospitals. Yeah, that's by nature, and that's logical. But what I'm trying to say to you is that not always the case. They are reporting that not always the case. Maybe the cases that they reported to me not that critical, yeah, to the patient, not that in the sense to do with life endangering or life threatening, but rather more in the cases where other things that less life threatening. So in conclusions, what we learned from this interview on how the lens of high reliability organization can be used in the case of healthcare operations, we know that high reliability does not seem to reflect the safety culture designed within the hospital, particularly in accident and emergency, but rather as a way to fulfill administrative duties. Okay, so the checks, the following the SOPs, sudden inspections, and those things that has been carried out, it seems to be only fulfilling the administrative duty. And this findings actually contradicts to the Wake and Sutcliffe findings who said that HRO should be, what's the word, should be rooted within the safety culture across the organization, yeah, rather than just administrative responsibilities. Number two, in that hospital where safety culture was weak, the high reliability organization is likely to depend on external pressures. Yeah, like they said, because they were asked by the government, they were asked by the regulations, they were asked by accreditations or some similar things. They carried out this high reliability operations. And they did this way. They depend on external force or forces rather than the so-called collective mindfulness that I mentioned earlier on. Yeah. So rather than rooted within internally or within the inside part of their organization, it was actually forces by the external pressure. And this is in contrast with the general assumption that HRO is a self-induced system rather than externally forced. And this is well documented in the literature of high reliability organization. Conclusion number three, we looked into leadership roles. We said that, of course, in this high reliability organization, you need to have a strong leadership because it plays a critical role in ensuring the success of a reliable organization. To some extent, the HRO principle have been applied by nurses, but like I have said before, and it's been reported by them, the reason why they are doing this is not because of the organization being reliable, but rather it's coming out from themselves as a form of moral responsibility that is embedded in their profession. Yeah. And so the profession of the healthcare professionals, they have this moral responsibility, and because they have this moral responsibility, automatically somehow it triggers or it promotes the safety culture. That's interesting for us. So what we're going to do in the future? So in the future, we need to further validate, we need to further test our initial findings by perhaps creating a model of high reliability organization to find a link, to better understand the link between a reliable organization and a safety culture. And there are a number of models that we have developed. One of them is this one, looking into operational reliability and performance of the high reliability organization. and we want to say to see whether the link between operational reliability is actually mediated by something else, perhaps by the organizational mindfulness or by environmental disruptiveness. So that's one of the models. The next model is this. So this is actually linked to, like I said to you before, a more generic science and engineering safety, where we look at the chain of safety culture that links to safety performance and linked to something else. So in this model, we look at the performance of something. So let me repeat. We have the domain of industry. Let's pick a domain of industry, maybe healthcare, hospitals, chemical industry, factories, whatever it is. And then we have the safety cultures, and these are the elements of safety cultures, for example, management values, risk and perception, safety systems, work pressure, competence. We propose that these safety cultures somehow influence the safety performance. And the influence of safety, the way safety cultures influence safety performance will be moderated by the type of industry characteristics. Yeah, and if we do that, if we demonstrated the safety performance, and that safety performance will lead to production performance, to something else, to any other performances. Yeah. So this is what, the other model that we have tried. We're now looking. We were now waiting for the results for that, the analysis of that, and hopefully when that's completed, I'll be happy to share my findings again to all of you. So before I complete my my presentations, and these are some lessons that we can learn. So what we are doing here, we're offering a lens, a theoretical lens, a systematic lens, to view the underpinnings of safety. So the way we see safety, of course, we have different ways. And my way of using or viewing this safety is by using the high reliability organization. And then we suggest that the success of individuals in terms of healthcare professionals in providing safe care can be amplified or lessened, or it can be strengthened or weakened by the organizations and institutions. That's what we feel it happens in our research. So with that, I finish my presentation. Again, thank you very much for your attention, and hopefully, if you think that this model or this theory can be used, I'm very happy to work together with you and try this model perhaps in the future on how we can improve this. Okay, so thank you very much again.
Yeah, thank you so much, Professor Tjahjono, for the interesting presentation. Now we are going to the next session, which is the Q&A session. So to the audience member, if you have any questions to either speakers, you can submit the question through chat, or by raising your hand. It seems like there's one question from Stikas Dharma Husada. Seems like it's from Astri Handayani to Stikas Dharma Husada Bandung. Yeah, Stikas Dharma Husada Bandung. If you don't mind, maybe you can turn on your microphone and ask questions to our speaker director. Stikas Dharma Husada Bandung. How do you say it? It seems like representation from Stikas Dharma Husada Bandung is not present, so I'm going to read the questions out loud to Ms. Rista. Is safety culture can be developed in family who care for elderly at home? To Ms. Rista. you want to answer the questions now, or maybe we can wait for another question. Oh, and to the audience member, if you have any questions in Bahasa Indonesia, in Indonesian, silakan ditanyakan melalui kolom chat atau langsung angkat tangan, sangat diperbolehkan untuk bertanya juga dalam Bahasa Indonesia. Yeah, Ms. Rista, perhaps you want to answer the question.
Okay. A very good question, because safety culture is something that not only about one practice, but also organization. There is a lot of dimension of the safety culture, like awareness, like staffing, compliant with procedures, training and skills, non-punitive response. Maybe in the family, not safety culture as not an organization, but only awareness for safety for family that caring for the older people. So maybe in the next future, if I think maybe it will possible to do safety, but it is only for safety awareness, but not for the culture, because sometimes in the family with the older adults in Indonesia, especially in Indonesia, there is unskilled or uninformal care for their family. So they treat their family, but there is not trained well. So it's little bit difficult to develop safety culture in the family. This is my answer.
All right, thank you very much, Mr. Fauziningtyas, for the answer. It seems like Ms. Ratna Dwi Wulandari, the head Department of Health Administration from Universitas Airlangga, is raising her hand. So Ms. Ratna, if you have any question, please ask.
Okay, thank you, Lydia. Good morning, Mr. Benny.
Good morning.
Okay, I have morning. Sorry if my internet is not stable here. Okay, I will try to give one question for Mr. Benny. Okay, very interesting perspective from your presentation. I cannot agree anymore. I capture one important aspect from your presentation, which is about collective mindfulness to safety culture. This is like a social capital that will drive organization to better condition, which is all the staff have the same perspective, feel that safety culture is valuable for all. Expected that all of the staff have the sensitivity to recognize every aspect that has potential risk, and hope they will share if they have a near-miss experience. But as we know, especially in Indonesia, the blaming culture sometimes still exists. Although in many dialogues, the manager always say that no blaming culture in their organization, and push staff to share stories about them. Thus, it is really there are other critical aspects, because I know that you have many knowledge about Indonesia. So I hope that you can give your perspective here. Thank you.
Thank you. I missed the last part of your questions actually because of the internet.
Yeah, Ms. Ratna, it seems like the last part of your questions were cut off because of your internet connection. Would you mind maybe repeating the last part of your question, Professor Tjahjono, please?
Okay. I the blaming culture. because we know that in many events, although in the organization, they always no, but in those related to the Indonesian culture or maybe some critical other aspect. Okay.
Okay.
You can got my question.
I will try to guess. I'll try to guess the question. It's about blaming culture, and of course, this. Yes, I'm familiar with that, and I think experiencing life in the UK also, we have that. I'm not saying that we don't have blaming culture, but maybe the extent of this blaming culture is different, and the higher the extent of blaming culture, obviously, the more difficult to deal with. Not only in terms of safety, but also more importantly in terms of innovation, in terms of creating new ideas. Yeah. So the higher the blaming culture, obviously the lower normally the people can think and can innovate. Yeah, because they're scared. If they do something wrong, they get blamed, and if they don't punished. Yeah, the punitive culture also pretty strong in that, and that's also. I don't know, maybe I'm wrong. Maybe recently this culture is getting better, but certainly because it's been rooted for so long in terms of bureaucracy, it's very, very apparent that sort of waiting for instructions. Yeah. So I'm sorry, Pak, I cannot move because I'm waiting for instructions from my boss. Waiting for, what's the word? Disposisi. I don't have the disposisi, but I cannot move now. Why can't you do? No. If I move and I make mistakes, I will be blamed. I will lose my job, whatever it is. So it does happen in the UK too. So recently I was told off by my boss. Why don't you do this? Why didn't you do that? But I thought, yeah, it's fine. But then when I say, okay, I'm sorry, I didn't realize that things happen and so on. And the positive thing is that the management encourages us to be resilient. So they're not keeping, my boss did not keep blaming me for that mistake I made, but rather encourages me on how to do it better in the future. So I'm sorry, but if I didn't answer the question, I'm just guessing from your questions early on.
How is it, Ms. Ratna?
Yeah, answer my question.
Thank you.
Yeah, it seems like Professor Tjahjono answered the.
Oh, is it? Okay, I'm sorry, I'm just guessing. Complete guess.
Thank you so much. Now, to the audience member, perhaps you have any other questions. Bisa disampaikan menggunakan bahasa Indonesia, tidak usah sungkan, bisa langsung raise your hand atau melalui kolom chat. So before we end this webinar today, I want to make sure that there are no more questions from the audience member. So we'll be waiting for the questions. All right, it seems like there are no more questions. Oh, there's one question from Ms. Inge Damanti. Ms. Inge, please.
Okay, thank you for joining the webinar today, Prof. Tjahjono.
Thank you. My pleasure, my honor to be invited.
Okay, so Prof. is the best mentor that I have. Always support me in applying so many things, but even though I didn't successful yet, but it's okay. Okay,
it's so good then. It's not good mentor.
I have the resilience, Prof. So yeah, that's good. Okay. I'm sorry for my background noise because my son is asking for snack. It's not a good time, but I just want to ask one simple question for Bu Rista and for Prof. Benny. So Bu Rista, your study is really impressive, and actually the finding, to be honest, related with the quality of care is a bit scary because we saw that the decline in the daily life quality and also so many infection. So my question is, how can we improve that? So because I think, I don't know, what can we do to improve that? So that's my question for Bu Rista. And for Prof. Benny, thank you again for sharing the perspective. And from your model, so the simple one, not the complicated one. I see that you offer two models, and for this, we start from the simple one. So where could we start to build the high reliability organization? From which factor we could start to build that in the healthcare organization? So yeah, that's all. Thank you so much once again.
Thank you.
Thanks, Nindya.
Yeah, perhaps Ms. Rista would like to answer first, or maybe Prof. Tjahjono.
Okay, maybe like the first. Okay, very good question. How to minimize the incident of the safety issue. Maybe the first, we have to increase their awareness, not only for staff who give direct care for them, but also for all of them, because security also have a responsibility to maintain the safety, also the kitchen staff and also the other. So we have to give training or some orientation for them to what is the safety what is the safety culture, what we have to do. And the second is limiting the blaming culture for every staff who maybe found error in the nursing home, or maybe they doing something that maybe affect to the incident. So just we have to try to look for what because it's what is the root of the problem, not blaming. And then second, the third is always documentation about the incident, about the something that maybe have a bad impact to the resident. Sometimes in the nursing home, they don't know what the incident for safety issues. They don't know. They just write about the how to fulfill their basic daily need, but for the health issue or safety issue incident, they don't know about it. So the first is documenting, and then the fourth is I agree with Prof. Benny, external factor from the government. The government must responsible, must give more force to create how system to maybe report or control about the safety in the nursing home, because until now is still lack of the reports. Okay, maybe it's enough. My answer. Inga, thank you.
I guess it's my turn now.
Yeah.
I agree with you, Bu Rista. I mean, Bu Inga always gives difficult questions to us. No, I'm joking. Yeah, I agree with you. That's what's interesting here to me as someone, you know, we have different background, and I'm a new kid on the block here. And what I'm trying to do here is to combine, to look out for different ways of analyzing this so-called safety, patient safety, from a different angle. And my starting point is to use this called high reliability organization theory that has been used extensively in different areas. For example, like I said to you before, in engineering systems, complex systems, into human systems. The only difference I imagine is that it seems to be that there are two layers of safety in the case of healthcare, and we look into specifically into the so-called patient safety. And the other layer is obviously the staff safety, the healthcare profession safety. Whereas in the engineering systems, there's only seems to be only one level, is our safety. If they are working in nuclear submarines, and the safety of everyone inside this nuclear submarine, not just the whoever consumers of that, or electricity, let's say if I work in electrical generation systems, then my safety is not just for my customers at home, but for everyone. Yeah. So that's one thing. And the other, there seems to be no link between the high reliability organizations and the antecedents of it. So there seems to be no discussions in the literature looking at the antecedents, and that's the HRO itself. What's interesting is that, and also there is no link with safety culture. So what I would like to do, what I would like to start is perhaps before we say, okay, these organizations are very successful in implementing the principles, or in other words, these organizations are highly reliable, I want to see what makes them reliable. Yeah. Is it safety culture? Is it something embedded inside us? Is it a pressure from external? Yeah. And this itself can be a very good starting point. And the third one is that I'm sure you are using this WHO principles, right, in terms of patient safety. And it seems, again, I found a nice angle to combine the pure perspective of healthcare that has been prescribed by WHO with other type of safety measures in another system. And if we able to combine these two together, I'm pretty sure that, you know, we can strive for a better outcomes in the future. I hope that's not all over the place. So the three things that I said to you before. The first one is looking on how the antecedents of this higher level organization, we can start from that until something like the WHO checklist on patient safety. I hope that makes sense, Boo.
Yes, Prof, thank you. And it gives like a lot of homework for healthcare organizations.
A lot of thoughts, isn't it? Because I'm equally interested in looking into trying to find a new area of applications. Yeah.
Thanks a lot. Okay.
So we shall work together more closely in the future. Boo.
Yes, sure.
All right, thank you very much. So I want to make sure again to the audience member, if you have any questions before we end this webinar today, perhaps you're curious about something, you can ask it, whether in English or in Bahasa Indonesia through chat or by raising your hand. Okay, we'll wait for a moment. Okay, it seems like there are no more questions. Therefore, the event this webinar today has finally come to an end. And once again, we would like to thank our amazing speakers. Thank you so much, Ms. Rista Fauziningtyas. Thank you so much, Professor Benny Tjahjono. Thank you for the amazing presentations. And we would also like to thank our participants for staying with us throughout this webinar. We still have another webinar tomorrow, so we would really love it if you would come to our webinar tomorrow with Professor Cyrus Engineer and with Ms. Damanti. So that's the event has now come to an end. This webinar, the recorded version, will be posted on our YouTube channel at Pusat Riset Keselamatan Pasien. So if you missed anything, please make sure to come to our YouTube channel and see this recorded version. On behalf of the organizer, I would like to apologize for any mistakes done throughout this event. And wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Good afternoon. Thank you so much, everyone.
Thank
See
you.
tomorrow.
Thank you very much.
Thank you, Professor. Thank you, Ms. Rista.